Okay, great, thank you. So, hi everyone. I'm going to present these slides that were prepared by Dr. Bott. I want to give him credit for this presentation. We have no disclosures, and this is just going through, again, how to receive the CEUs for this talk.
Or CMEs, yeah.
Or CMEs, yes. And I will keep this to about 20 minutes at most, I hope, so that we leave plenty of time for Rayon's case. So this talk, co-occurring substance use disorders and mental illness, an introduction. Dr. Bott put my name on here because I'm presenting for him, but I want to give him credit because he prepared these slides for us today. He is out of town. No disclosures. The objectives today are to appreciate how to differentiate between substance-induced and independent psychiatric illnesses, learn about comorbidity between substance use disorders and various psychiatric illnesses, and then construct a treatment approach for patients with dual diagnoses with opioid use disorder and other psychiatric diagnoses. So let's go over definitions and epidemiology. This is the next two slides are from 2016. And this one that you're looking at here shows past year substance use disorder and mental illness among adults. And you can see that basically what we're looking at is that overlap there in orange of substance use disorder and mental illness was at about 8.2 million, and then no mental illness there on the left at slightly greater at 10.8 million, so substance use disorder alone. And then over here, the majority with mental illness and no substance use disorder identified. And this is a different slide that's looking at the same year, but data that is comparing substance use disorder and serious mental illness, such as schizophrenia, bipolar disorder, and you can see the overlap there in the orange of 2.6 million. So what we know is that substance use disorder increases the odds ratio for a psychiatric illness, and vice versa, that a psychiatric diagnosis increases the odds ratio for a substance use disorder. And then lastly, we know that one substance use disorder increases the chance that someone may have or will develop an additional use disorder. So, and then just touching upon again substance use disorders and severe mental illness, we see that, and this is kind of going back to that data that we just looked at, that people who have substance use disorder have about 4.5 times greater risk to have a comorbid psychiatric condition. And then likewise, those with a psychiatric disorder also showed about 4.5 times greater risk to suffer from a substance use disorder. Schizophrenia and affective disorders and anxiety disorders were the most prevalent diagnoses. And again, this is kind of breaking down the prevalence for you. So with an N of 463,000, the prevalence of any lifetime substance use disorder identified, you can kind of go through that list. I won't read them all, but the highest prevalence again being for those with schizophrenia, and then going down to the bottom of the list there, 11% risk of OCD. And in this list of diagnoses, alcohol use disorder was the dominant substance use disorder in every category listed. And then also of note, patients with substance use disorder were more likely to be men, had fewer years of education, and more often received a disability, and importantly and sadly died due to unnatural causes such as accident, overdose, suicide, homicide. Here is a list from the Journal of Drug Addictions and Substance Misuse, also from 2016, that looks at consequences associated with concurrent disorders. So severe is looking at severe mental illness and substance use disorder. And we see a variety of consequences ranging from hospitalizations, increased number of suicide attempts, violence, discord in the family, social life, and then medical comorbidities such as infectious disease, and higher rates of unemployment, homelessness, and trouble continuing with therapy and having success with therapy. So moving on to the assessment, and I think this is what Dr. Bott really wanted to focus on in this presentation. How do we assess for these co-occurring psychiatric illness and substance use disorders? So with the patient who presents intoxicated, you're basically just really trying to approach safety in that moment, right? So we're screening for suicidality and homicidality, assessing their stability with their exam, including their vital signs, and then attending promptly to these medical symptoms and managing their immediate withdrawal symptoms. And the key here is that we don't, in an intoxicated patient, we don't want to continue with a thorough psychiatric evaluation. It's more important to wait until they are no longer intoxicated. So how do we distinguish between substance-induced versus an independent psychiatric condition? So for substance-induced disorder, these are related to the use of the psychoactive substance, and they should resolve with a sustained period of abstinence. For independent disorders, these should present during times of abstinence, and the symptoms are not necessarily related to use. Of note here, there's not a specific time frame that has been established to reliably distinguish these disorders, and so it is, I think another slide later on goes into the potential difference of approaches for time frame, but it comes down to a clinical judgment if it seems like the patient has been not using or withdrawing from substances within a significant amount of time where you can make an assessment. So substance-induced disorders, these symptoms should only occur when patients are experiencing the effects of their drug use. Symptoms are related to either the period of intoxication or the withdrawal symptoms or other aspects of their use. And the time frame is important. So the onset or the offset of symptoms is typically preceded by increases or decreases in their use. And so the goal for evaluation is once again someone has experienced a period of abstinence to then reevaluate their symptoms. So for independent psychiatric disorders, these symptoms will occur when someone is not using, right? And so with steady use, or with steady use without changing the amount or type. So again, it seems that they are not related, the symptoms, to specific substance use. And one thing that can be helpful is a family history. Oftentimes this can point to an independent disorder if first-degree relatives are affected by certain psychiatric diagnoses that may be consistent with your assessment of the patient. And so the goal here is sort of parallel treatment of both, so helping them to stop using the substance and also treating their psychiatric symptoms, because treating one while waiting for the other is unlikely to be effective. So the pearls from this assessment, again, the family history can be helpful, and then inquiring about when they first experience these symptoms to see if perhaps they preceded any initiation of substance use can be a helpful part of the history. And then, do they continue to experience symptoms during extended periods of abstinence? And then the other thing that can be important is if you're unable to have an assessment that helps you distinguish those things, observing what happens as you treat somebody. So for instance, if we get someone stable on buprenorphine who's experiencing opioid use disorder, what happens with those other symptoms once they're not using? This is a pretty busy slide. I'm not going to read it all, but this is a table that's looking at primary mental disorder versus substance-induced disorder. And you can kind of glance through that on the left. You see, so the table is looking at differential clinical characteristics between these two. On the left, you see the primary or independent disorder, and on the right, the substance-induced disorder. So you can kind of distinguish there between if there's a chronological association or not, how the symptoms persist or do they remit, the family history, personal history, and so forth. So the next few slides are looking at different things that you might observe or the patient might report with different substances. And what Dr. Bhatt's done here is in red, you'll see the symptoms that can be present with the substance use disorder if there is a co-occurring psychiatric disorder. But then in blue, you'll see these symptoms from the intoxication or withdrawal state, but you shouldn't see these symptoms from the psychiatric disorder. So for instance, for alcohol, if we look at an state of intoxication, we may see mood, labile mood, inappropriate or aggressive behavior, impaired judgment, impaired attention, impaired functioning. Those can all be effects of intoxication. And however, in blue, the slurred speech, incoordination, unsteady gait, nystagmus, impaired memory, stupor, coma, we shouldn't see these from someone, for instance, who's experiencing bipolar disorder. So we would expect that these things would go away once someone is not in a state of intoxication. Same for withdrawal. We may see anxiety, insomnia, agitation, hallucinations, and we wonder, well, how much of this could be from their underlying mood disorder versus the withdrawal state. However, in blue, what you see there, the tremor, nausea, vomiting, seizures, delirium, we would not expect that from the psychiatric comorbidity, but from alcohol withdrawal alone. So these next few slides, again, can kind of help distinguish what's going on in these two states. So similarly, for stimulant use for intoxication, things that you're, I'm sure, quite familiar with seeing are some of the anxiety, anger, weight loss. You might see hypervigilance. I'm not going to read through the whole slide, but again, in blue, though, those symptoms that you see in intoxication, you would not expect to see from a psychiatric illness alone. So the vital sign abnormalities, sweating, chills, etc. And then in withdrawal, I think for the stimulant use withdrawal, it can be hard to distinguish, and so we tend to see these symptoms which could be attributed to both withdrawal and the a psychiatric comorbidity. So again, things such as fatigue, insomnia, increased appetite, vivid unpleasant dreams. These are things that we can see in both states. For cannabis, again, intoxication, we might see some social withdrawal, anxiety, paranoia. Those could be potentially from underlying psychiatric disorder. However, in blue, the impaired coordination, tachycardia, we wouldn't expect from the psychiatric disorder alone. And then in the state of withdrawal, again, withdrawing from cannabis use, we might see depression, irritability, anxiety, insomnia, which could be also symptoms of depression or bipolar disorder, for instance. But if they're having headache, shakiness, sweating, nausea, we would expect that to be from the withdrawal state alone. And then same for opioids. You can see there again for intoxication state, the differences that you might observe in red, the ones that could be present with both intoxication and an underlying disorder, and then in blue, what you would expect just from opioid intoxication alone, right? So the drowsiness, respiratory depression, stupor, that we wouldn't expect from, say, bipolar. And then withdrawal state, again, in red, those are the symptoms that you might observe in your patient. However, in blue, those symptoms, again, such as nausea, vomiting, muscle aches, all of that we would expect just from the withdrawal state alone. So these are some ways to kind of distinguish between co-occurring and not. And then for nicotine, here he has the withdrawal state, that there's quite a bit that can overlap. However, bradycardia, withdrawal from nicotine, we wouldn't expect from a psychiatric illness alone. So it might be helpful to go back through those slides and kind of pull apart some of the symptoms to be able to kind of summarize what you'd expect to see for each of those substances. Okay, so moving on in the last few minutes to some treatment considerations. So I believe this is a picture from that Dr. Romo contributed to this talk. I remember this of the ship sinking. And this is what is the importance of dual diagnosis. So if you have two holes in one ship, so if you're experiencing a substance use disorder, but also severe depression, let's say, and you're only treating one, then the ship still sinks. And so it's important to treat both concurrently, plug both of the holes, I think is what they're getting at here. So a substance-induced mental illness and dual diagnosis, it was previously thought, so this is going back to the time frame, that you would need over 6 months of no use in order to distinguish the two and in order to move forward with treatment. This has been revised to a month of sobriety. That's sort of what many clinicians refer to in terms of kind of having enough time to be able to distinguish between co-occurring and not. But really the key is the dual diagnoses need to be treated at the same time and not one after the other in order to offer the most opportunity for success. And it's also important to remember that substance use doesn't equal substance use disorder, so we need to pull out our DSM-5 and assess if the patient actually meets diagnostic criteria for substance use disorder, as opposed to having occasional use but not meeting the criteria for an actual use disorder. And this helps inform the most appropriate treatment for that patient as well. In terms of steps to treatment, for step 1, psychotherapy, definitely consider psychotherapy as first-line treatment in patients with substance use disorder and less severe depression or anxiety. And for pharmacotherapy, for initiating that, it's important to wait until they are no longer intoxicated, and certainly to initiate this sooner than later if they have more severe symptoms at presentation. So in general, in summary, depressive and anxiety symptoms are common when we first have patients enter treatment into for their substance use disorder, and these symptoms can resolve sometimes within a few days once they've stabilized on treatment. So for symptoms that persist beyond that period of acute intoxication and withdrawal, then it's important to consider prompt treatment. And if pharmacotherapy is being considered, something such as SSRIs are oftentimes most appropriate. Patients who have been treated with, who are treated with buprenorphine, MAT, we know that these patients respond to medications for depression and anxiety at rates that are similar to folks who don't have opioid use disorder. And another pearl is to try to avoid medications that can be addictive, such as benzodiazepine and stimulant medications if possible. And if they do turn out to need such medication after thorough evaluation, then it's important to monitor their treatment response and the appropriate use of these medications. And so what medications are recommended? You can see the list here. For depression and anxiety, the SSRIs, SNRIs are good first-line medication. For social anxiety, paroxetine is often recommended. PTSD, again, the SSRIs, specifically sertraline, paroxetine can be quite effective, venlafaxine as well, and prazosin. And then for bipolar disorder, the valproate has been found, at least for co-occurring alcohol use disorder, to be more effective than lithium alone. Than lithium, which oftentimes folks will turn to for bipolar disorder, but again, the valproate's there as a recommendation for that co-occurring bipolar and alcohol use disorder. And then this is just summarizing again in a table form for you the receipt of mental health services and specialty substance use treatment in past year in adults who have co-occurring mental illness and substance use disorder. You can see here in blue of 8.2 million adults, the percentage breakdown. So in blue, the mental health services only, about a little over half with no treatment, and then a small portion of the pie here receiving both a treatment for both, so just at about 7%, and then the smallest portion at 3% of the substance use treatment only. There's one more slide. And again, this is also breaking it down now into, this is for adults who had a serious mental illness and substance use disorder. And you can see here the no treatment is a little bit less, mental health services at about half, and then again, the combination at about 12%, so slightly more. And then this is, I think, our last slide. So SAMHSA recommends an integrated approach to treating co-occurring substance use disorders and mental health disorders. They encourage collaboration across disciplines and having a patient-centered approach. And this has been associated with lower costs and better outcomes, which are measured by reduced substance use, improved symptoms, decreased hospitalization, increased housing, fewer arrests, and improved quality of life. And here we just see that we like to have all of these treatment goals worked on in parallel. And I like that hope and respect are part of their circle here. So that is the end. We're right at 12:30. I